speaker is Piali Day. Piali Day is the co-founder and CEO of Sencio Systems. She was also a former engineer fellow at Raytheon Integrated Defense Systems, inventor of Confluence knowledge-based decision support in military and public safety missions, accomplished many researches, including decision support systems, mission performance predictions, analysis and optimization, intelligence systems, automatic target recognition, including real-time implementation, sensor fusion, and physics-based simulation of infrared emission and photon transport. She was a former senior scientist at Spectral Science, Inc., and she's a Boston College alumni. Please join me in welcoming Piali Day.
Good evening, everyone. It's a beautiful evening, and it's just lovely to see you all. I think the best way for me to start my conversation is to say we're doing what Cupid and Michael Doyle's company is doing with EHR data. We're doing it in the home with data about chronic conditions in the home. And the answer, you're absolutely right, the answer lies in an interpretation of all the data that is informing of anybody's health situation, and that happens to come from all settings. There is the data that's in the electronic health record systems that's coming from the clinical setting. There is the claims data. There's a lot of insight that can be derived from that. But there also is a hugely untapped source of data, which is about behaviors in the home. And what I'm going to talk about is care coordination for management of complex chronic conditions, multiple comorbidities, and what's happening with patients with multiple comorbidities living day in and day out is what's happening in the home. And so that's the focus of our conversation. And with that, I'll also caveat, and I'll agree with Michael, that there is so much data that's available that is not subject to human interpretation. There aren't enough people in the world to look at all the data that perhaps comes from my grandmother every single day. It's got to be systems that automatically interpreting it. So my talk is about automated sense making for coordination of complex care with the data that can be harvested from the home. So the complex health challenges, what we just as a society have to wrap our heads around. More of us are just entering that retirement, 65, 70, 80s age, and most of us will live with multiple chronic conditions, and most of us will fortunately live with multiple chronic conditions for a couple of decades, maybe even 3 decades. And if those conditions are not properly managed, we all know that it leads to higher incidences of hospitalization, more use of emergency rooms. Cost is much, much more for folks with multiple comorbidities. And the essential healthcare challenge that we face as a society, and it's a global challenge, it's not just America's challenge, is knowing how to manage people with complex care day in and day out. And we are an incredible system here in the US about acute care. When people go into the hospital, we know exactly what to do to patch them up, send them home, but then we forget about them when they're in the home. But we can't do that. So we've got to now cross that bridge from patching up in the hospital to having total situational awareness within the home and to reach into the home and intervene in a timely fashion. And that's the solution that we are after. So the challenge for complex chronic care is absolutely amazing. Cal mentioned that somebody with diabetes, well, people may start with diabetes, but very often they end up with a heart disease and then a lung disease, and they have a myriad set of specialists. They've got their primary care physician, and on the other side, their support system is their family, their community. That's where they're dwelling, that's where they're spending their time. And this bridge between the support system that is there for you 24/7 and the specialist system that is there to patch you up when something starts to go wrong, that is the gap, that's the care gap that we have to fill. And our solution is intended for the folks who are filling that care gap. Out on the clinician side, we've got the electronic health record systems. Out at home, maybe we've got logs. Okay, maybe we've got daily phone calls with mom. But there is nothing that transcends the two. But the tools that we are bringing to the market connects the two through technology. And the people who are using it are extension of the care team that we are evolving into, and they are two very, very critical people that we have discovered through experimentations in bridging this gap with our multiple customers, and that is a patient advocate who's going to reach out into the home about all issues behavioral. How come you're not eating enough? How come you're not walking around enough? Why didn't you fill that prescription? It looks like you're not taking your meds, and that's having an impact on your blood pressure. What's going on there? So there's all of that social conversations to be had, and then of course if the blood pressure spikes or glucose drops, there is the clinical piece that also needs to be managed, and that is handled by the care coordinator. So putting in that safety net between what is acute care that we have perfected in this notion and the home care which we have failed to attend to is where our solution lies. So the promise of coordinated care that we are pursuing is threefold. One is we've got to empower patients and families to take the right action every single day. And oftentimes when they don't, it's because it's too complicated for them and they don't know what to do. So our tools completely begins with empowering the patients and the family members. But it can't stop there, because if something bad starts to happen in the home, someone has to intervene. And that is a complex care portal that we have developed that even not your primary care physician, but a tier 2 clinical system is going to attend to. But ultimately the goal is, as Michael said about Cupid, is understanding what's your population like. So if I'm an ACO responsible for 100,000 patients, I want to understand how many of my diabetics are not taking their metformin, is getting into regular episodes of glycemic complications. Understanding that your population at that level of granularity, which is the events that are happening in the home every single day, is where we think the power of transformation lies. And that's the analytics that we focused on. So our system is IBIS. There is a demo system back there that perhaps you'll get a chance to look at. But essentially, the system consists of a care station, which is a nice 17-inch touchscreen device. We have 94-year-olds using it. And just big buttons which tells them what they need to do on a regular basis. 2 o'clock every morning, we lay out their daily care plan, and that includes all the meds they need to take, sequenced into when they need to take it relative to their meals, when they should exercise, if they have doctor's appointment. So here's your calendar laid out for you as it pertains to your chronic care for that day. So that's one level of activation, but then we're also analyzing everything you're doing in real time. So if your blood pressure spikes, we now start to activate you through a protocol for addressing episodic hypertension, while we send a notification out to your clinical team saying you are having this difficulty, be aware. The second component of our system is actually a passive set of devices for monitoring activities of daily living. We think that if you could just watch a person's movement, especially an elderly person's movement, it is very telling of how they're feeling. So we've got this passive activity monitoring system that's going to tell us if with the quality of sleep, the duration of sleep, was time spent in the kitchen cooking, the normal amount of time was time spent eating. Of course, it'll tell us about falls. Were there too many trips to the bathroom? Was the person even just too slow to get out of their chair that day? And is this a pattern that's repeating itself? Well, they could be cognitive issues, they're mobility issues, but they're caused by something. And it's that cause that we are applying artificial intelligence to discover. Are you less balanced on your feet today because you forgot some meds, or you double dosed on some meds, or you have a new med. What's going on in your home with respect to your clinical care that is impacting your health and mobility? We are integrated with devices that automatically collect physiologic and environmental data, but the essence of it all is intelligence. We spent the first 2 years of our company's lifetime developing a very robust AI framework, which actually has its roots in, I came from the defense industry, a lot of intelligence data that need to be contextualized. So similar paradigm that we are applying here to understand how behavior impacts health. That's the essence of our view. And then we communicate all the insights through a care portal. And at the heart of all of this is automated interpretation of data. So the system constantly collects data, it interprets in real time, and in real time it notifies people, and on demand it creates reports. The on demand function really is when a person has been scheduled to go see the primary care physician, hit a button, what has happened with this patient on a day-to-day basis since I saw him or her the last time. And that's what we are doing. Examples of sources of data, you're all familiar with it. Movement sensors, wearables, cameras, interactive devices, light sensors, biometric devices. And this is a good thing. We're going to just collect more, we're going to find more ways to pick up subtle cues about a person's situation in the home, but then we're providing the brain in the box to interpret it all towards answering some specific questions. And the type of questions that we are specifically answering is the patient taking his or her medications? Is he getting the right kind and the right level of exercise at the right time? Are they taking their meds at the right time? Sleeping well, depressed, blood pressure under control, medication having its desired effect. This was a medication to control the blood pressure. Is the blood pressure controlled? What are the risks of a hospital admission if we do not intervene at this moment? That's always a choice, when to intervene. Intervene tonight, intervene tomorrow, what does that look like? So those are the questions we are answering. And as I mentioned, we begin with a deep patient engagement system, touchscreen device, really easy to use. We are telling people what medications they need to take, when they should take it, etc. And then we're guiding people through clinical protocols, which are given to us by our customers. Our clinicians provide this system as a tool to their patients to help them manage their complex care. And this is the activity of daily living. We can look at it on an hourly basis, but more importantly, we can look at it as a trend basis and notice that someone's level of activity is slowing down over perhaps months. And those are all cues on what's going on. And why is it happening is what we are attempting to discover with the AI on the background. And at the end of the day, we are our care portal obviously displays a variety of data, but we are sending contextualized notifications that tell you what the situation is and what is our hypothesis as to the reason we are in that situation, missed meds, etc., etc., and allowing that early intervention. And we don't stop at that. Our goal really is to do this at the population level. So we are clustering in real time the patients by their behavior. So here's, for example, a diabetic population, perhaps with other comorbidities, whose medication and dietary adherence has certain impact on their hypoglycemic events. And so what does your clustering look like now, and how does it change in real time? You can watch a movie and see, oh my gosh, I've got this population shifting into this population. If it's a good thing, give yourself a high five. If it's a bad thing, do something about it, like do some training, do some coaching. Examples of population insights from IBIS. What portion of my population has poor diuretic adherence leading to fluid retention? Okay. A poor diabetic medication adherence leading to hyperglycemic events. We are seeing this day in, day out, and we're doing this every day with our population. Meal skipping leading to hypoglycemic events. That midnight snack, you didn't get up to take it. Well, let's tell you how important that is, because otherwise next morning you'll be in a world of hurt. Breathing difficulties as early indicators of COPD flare-up. etc., etc. And whatever the question wants to be, if it can be tied to observations made in the home, we will tie it back and forward reason to establish that connection. I'll end with a case study. This is a 70-year-old female with COPD. And this is the individual's overall adherence to the care plan. Pretty good, pretty steady, approaching almost 100%, does everything she should be doing. But there was a period somewhere between 40 and 45 days into the program where she did miss a few critical meds for a few days in a row. Never mind, she picks herself back up and she gets back to her good adherent behavior. But we also do query every single day, how are you feeling? Just a simple question on a 3-point scale. Same as yesterday, better than yesterday, worse than yesterday. And starting about that period of time, we noticed that she progressively kept saying worse, 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 worse. That was the first clue that something wasn't going on right. The second clue was after a few days of not feeling well, she started to report my breathing's harder. Because again, we ask periodically, not actually we ask every day. The care plan is completely customizable. And so we detect a labored breathing. We detect a worsening cough. But the number of triggers, the number one triggers that was in our protocol, whether the O2 sat fell below a threshold or not, never happened. And there was a hospitalization event around day 56. But now we have changed our protocol to also look at, I'm not feeling well as the first indication something's wrong, labored breathing as the second indication, worsening cough. So it is all this stuff that's happening in the home that we can harness and do that timely intervention. And that is how I feel there's a fundamental opportunity here to reinvent the way we do chronic care. With that, I shall just conclude with saying that the health data is ubiquitous, and that's a great thing. There is clinical data in the electronic health record system, there's claims data, and then there is all this data that the wearables and other sensors are collecting. They need to be harnessed for real-time decision making. And to the largest extent possible, that those data need to be processed automatically. That's where artificial intelligence comes into play. The intelligence community has been doing this for an awful long time. I mean, yes, lots of people are sitting there watching the predator data, but there also is an awful lot of automated reasoning that's going on. And connected coordinated care is the future of chronic care management. We will learn to do it, and then we will excel at chronic care management just as well as we excel in acute care, and we would have walked the spectrum of that which will cause us to be ill. And that's it. She had her hand up.
I have a bolder goal, which is chronic disease cure.
Yeah.
Reverse engineering. I actually think it's quite doable with what we know about genetics and toxic triggers. So is that a future goal? And then I ask everybody, when will you include dental? Because it's huge.
I agree. Dental has huge early indicators around diabetes and its transition into heart disease. We'll add dental anytime. We can do that. Okay, I'd love to talk to you. My team is back there. Would you, if I don't connect, please? We will add dental anytime. We just added depression. So we've got COPD, pneumonia, hypertension, diabetes, heart failure, and depression is what we're tackling. We will add dental in a heartbeat. Because it is about the totality of care. You can't miss out. If you miss out on clues, you are taking risk. And if you can avoid taking that risk, that's a good thing.
You said that you're going to notify the care team. Now, there's alarm fatigue everywhere. How do they know exactly if this alarm requires immediate attention?
Yeah, so that's built into our protocol. So our customers tell us what notifications they want to receive and what they want to be told about that situation, and it's a personal choice. Many doctors are not choosing to get the hypoglycemic alerts, but probably the COPD flare up and the fluid retention flare up. So they choose that based on how they want to practice medicine. But what they are doing is that ever so often they are reviewing our dashboard to understand what has happened in between the adverse, what we call the adverse events at home. And the population analytics, of course, tells them that we cluster the population into good adherers with good health, good adherers with poor health, poor adherers with poor health, which you would expect, and poor adherers with good health, which are people at risk. You do want to keep your eye on them.
So the cost of putting these sensors in a patient's home to gather the data, is that borne by the insurance companies, the patients themselves, or some other third party?
So we have 4 customers right now, and this year we're experimenting with the different types of customers. So we have an ACO who is bearing the cost. We have an independent assisted living environment that's putting this in every resident's home, because they want to have a clinical baseline so that if something bad presented itself, they have more data upon which to make a decision as to send this person off to the emergency room or not. We have a couple of government programs, Medicaid. We're really primarily going after the dual eligible population, children with disabilities, coordination of their care, education, social needs, multiple specialists, while you're trying to teach this child to be as independent as they can possibly be as they go into adulthood, because as soon as they cross that 21, the social services just go away. So it's Medicaid, Medicare funding that is funding this, either through a ACO type incentive. We can go to the private pay market, but we're not doing that right now, because we want the clinical setting to take note and start to change our culture.
How successful have you been in getting the patient to remain adherent?
Yeah, so I'll talk about 2 things. We look at usage, and we have patients who've used this system pretty much every day for 2 years. So there are the patients who either fall in love with it, like we do with our cell phone. We don't leave home without it. It is the way that they stay in command. And then there are people, we probably lost about 30% who would say, it's not for me, my care isn't complicated enough, I don't worry enough, my children are not worried enough. It's a variety of factors that get someone to glom onto this as if it was their life preserver. So those who do, use it indefinitely. We've lost through the system, and we've lost a few, used it till the last day of life. And it really is because we make it fun. Your family pictures can be uploaded by your family members. We're adding gaming this summer. We just want it to be a assuring and engaging environment. Did I answer your question? Back there?
So you're saying the care plans are customizable for each patient. Did you have some sort of like a baseline care plan depending on what the condition is for that patient, or is that conditions?
So we have certain portions of the care plan. We have baseline monitoring. We have the standard recommendations, but the meds, of course, is the biggest part of the base plan, of the care plan, and that is purely customized. So behaviors around diet, exercise, and symptom monitoring, we have some standardized component that one can just choose, but then customize and tailor from there on.
In that last slide you had around the COPD condition, is that the typical experience that you see, that type of slowly sliding curve as opposed to something steeper?
Yeah, that's what we're seeing. We're discovering amazing things about how gradual all of this is. It's just that it feels sudden to us because we missed all those gradual indicators.
Does your system address transition of care from hospital to handing it over to a primary care physician?
So our first deployment, the ACO did use it as a transition of care because they were trying to avoid the hospital readmission. So the patient consents in the hospital. When they go home, their care plan is already there. The first home visit, the device comes to their home. They are trained, but we are about longitudinal care. None of them have stopped using the system, so we go from transitional care to long-term care.
Does the primary care get notified immediately?
Yes, that's actually been the greatest benefit. It has been astonishing to me how much in the dark the primary care physician is as soon as an acute event happens. I don't understand that. It's not right for anybody. So notifying the primary care physician, no matter who made the decision to admit or anything, is what we do. All right, well, thank you. Oh, think there's one other question. Do I have time to take one more question?
The caregiver accepting this, because as I know, the primary doctors are paid per visit. They're not paid by emails or text messages.
Sure.
So how are they accepting this?
Yeah. So the primary care physicians are not the primary users. It is the care team, which an ACO, pretty much every ACO is now setting up a care team for complex care, high-risk care management that is using the system. But as of this year, Medicaid is reimbursing primary care physicians about $43 per patient per month to provide this kind of oversight on medication adherence, medication reconciliation. So it is becoming that it's also going to be allowed fee for service. Okay. Thank you.